I was reading through this study from Los Angeles General Medical Center this morning, and it really made me rethink what medical failure even means.
Okay.
Usually, when a treatment fails, we think the drug just didn't work, the bug was resistant, the tumor didn't shrink, something biological.
Right. Classic pharmacological failure. The molecule itself didn't do its job.
But this paper, it's called the Ambition Protocol for HIV-associated cryptococcal meningitis. It presents this totally different kind of failure.
Huh.
It's a failure that has almost nothing to do with the molecule and everything to do with the experience of taking it.
I think I know where you're going with this.
We're looking at a standard of care that was so grueling that over a third of the patients, they walked out of the hospital before they were done.
Which is, when you're dealing with cryptococcal meningitis, that's basically a death sentence. This isn't something you can just go home and manage. It's a fungal infection of the brain lining, and it mostly affects people with advanced HIV. If you don't treat it, mortality is 100%.
And still, 34.6% of patients in the control group, the before group, they left against medical advice. That number, it stopped me cold.
It says the treatment was almost as bad as the disease itself.
Exactly.
And that's really the core of what this study gets at. For decades, the best drug we had for this, amphotericin B, has been effective, but it's also notoriously toxic. We have a nickname for it on the wards.
Amphoterrible.
Amphoterrible, exactly. And so this study isn't about inventing a new drug. It's about proving that if you radically simplify how you deliver the drug, you don't just make it more convenient. You save the whole treatment plan from just completely collapsing.
So let's ground this in the study itself. It's a pre-post cohort study. They looked at the old way from 2020 to 2022, and then they compared it to the new way, the Ambition Protocol, which they implemented from 2022 to 2024. And the setting is so important here. This is not some fancy research hospital.
No, not at all. This is Los Angeles General. It's a huge safety net hospital.
So what does that mean for the patients?
Well, the paper says 80% of them are on Medicaid. Another 5% are uninsured.
So that implies a whole different set of pressures on these people's lives.
Exactly. You're looking at a patient group that's 90% male, median age around 40. And you have to think about the opportunity cost of being in a hospital.
They can't afford to miss work.
They can't afford it. They might have unstable housing. So a 2-week hospital stay with daily infusions isn't just a medical problem, it's a potential catastrophe for their entire life.
Okay, so let's dig into that old way, the control group. What did that actually involve?
It was 14 days of daily 5E infusions of a drug called lipid complex amphotericin B, plus another drug, Flucytosine.
So besides just the time, what is physically happening to these patients for those 2 weeks?
Well, you have to understand how amphotericin works. It punches holes in the fungal cell membrane, which is great.
Okay.
The problem is the fungal cell membrane looks an awful lot like our own cell membranes, especially our kidney cells.
So it's friendly fire?
It's a ton of friendly fire, particularly on the kidneys. The drug clamps down on blood vessels in the kidneys and just directly damages the cells.
What does that feel like for the patient?
It's awful. The body starts wasting potassium and magnesium. So every day, they're not just getting the antifungal, they're getting these huge bags of electrolytes. Potassium infusions burn like crazy going in. They get fevers, nausea, and these uncontrollable shaking chills.
Shake and bake.
Shake and bake, yeah. So imagine you have the worst headache of your life for the meningitis itself, and then the treatment gives you a severe flu while actively wrecking your kidneys.
The numbers in the study were pretty shocking.
They were. In that control group, the rate of severe adverse events was 61.5%.
So 6 out of 10 people had a major complication from the treatment.
A major complication. It's this awful cycle. The patient feels terrible, their labs look awful, the hospital stay gets longer to manage the side effects, and eventually the patient just says, I can't take this anymore, and they walk out.
And that's the failure we talked about. It's not that the drug didn't kill the fungus, it's that the regimen was just incompatible with being a human.
Correct. So that's where the Ambition Protocol comes in, the new way.
Okay, so what did they change?
They switched to a single-dose strategy, but with a slightly different version of the drug, liposomal amphotericin B.
Wait, okay. The old one was lipid complex. This one is liposomal. To me, those sound like the same thing.
It's a really good question. It comes down to the engineering. Think of it like a delivery truck. Both use fat to carry the drug,
Right.
but the liposomal version is like a high-tech armored truck. It's a tiny, stable sphere that holds onto the drug much more tightly in your bloodstream. It doesn't just randomly leak its toxic cargo onto your kidneys.
So it's more of a guided missile than a carpet bomb.
That's a perfect analogy. It's much more precise. And because it's so much safer, you can give a huge amount of it all at once.
And that's the single dose part?
Exactly. The Ambition protocol is one big infusion, 10 milligrams per kilogram on day 1. That's it for the IV.
But how does one dose cover them for 2 weeks? I think it would just wash out of your system.
That's the really clever part. The liposomal formulation has what's called a very long tissue half-life.
Meaning?
It soaks into your body's tissues, especially your liver and spleen, and then it slowly leaches out active drug over the next couple of weeks. You're basically loading the patient's own body up to be a 2-week drug dispenser.
So their body becomes the pharmacy. That's
It
fascinating.
really is. So they get that one IV infusion, and then for the next 14 days, they just take pills. High-dose fluconazole and flucytosine, no more IVs. No more daily kidney damage.
All right, so let's get to the results. Because the difference is just, it's night and day.
It is.
They define success as being alive at 10 weeks, no relapse of the infection, and this is the key part, no severe side effects.
And that definition is everything. In the control group, the old way, the success rate was 35%.
Which is terrible.
It's terrible. Now, the Ambition group, 76%.
Wow. That's more than double. The p-value is 0.06, so it's a very real effect.
A huge difference.
But I want to drill down on why it was so much better. Because when I looked at just the mortality numbers, just, did the patient die or not, they weren't actually that different.
No, and that's a critical point. We have to be clear about this. Mortality was about 19% in the old group and almost 12% in the new group. With this many patients, that's not a statistically significant difference.
And recurrence of the infection was basically 0 in both groups.
Right.
So the single dose didn't actually kill the fungus any better than the old 14-day regimen.
Correct. This wasn't a win for better biological efficacy. This was a win for better clinical utility.
Meaning?
The huge jump in the overall success rate came almost entirely from cutting the toxicity.
The severe side effects dropped from 61% down to about 20%.
Exactly. You cut the severe side effects by 2/3.
And that seems to connect directly to that other number we started with, the patient-directed discharges.
It absolutely does. The number of people leaving against medical advice dropped from almost 35% down to just under 12%.
You kept them in the building.
You made the treatment bearable. You removed that daily friction, that daily punishment. A patient who feels okay on day 3 is much more likely to stick around.
And there's another point there. Even if they do leave, say, on day 2...
They've already got the full dose in their system.
Right. In the old way, if you leave on day 4, you're massively undertreated. With Ambition, if you leave after that first day, you've technically gotten your full induction course. You're covered.
It's like a safety net within the safety net. It's a system designed for the reality of these patients' lives, not for a perfect clinical trial.
Which brings up the messiness of the data. I mean, the authors are upfront about this. It wasn't a perfect randomized trial.
No, and it couldn't be. But you see the real-world challenges. Look at how many patients were lost to follow-up.
Yeah, it was about a quarter of them in both groups, just gone by day 90.
That's high. It means we don't know for sure if they survived. But what's interesting is that it doesn't really weaken the main conclusion.
Why not?
Because the main benefits, the lower toxicity, the fewer people leaving the hospital, those things happen during the initial admission. We saw that with our own eyes. The loss to follow-up just proves how hard this population is to track, which, if anything, makes the argument for a single-dose, front-loaded treatment even stronger.
That's a great point. If you know you might lose a quarter of your patients to the wind, you better get the most effective treatment into them on day 1.
Precisely. It's a harm reduction strategy applied to pharmacy. You design for an imperfect system.
So, zooming out a little, this is clearly a huge win for HIV care. But I'm thinking about the bigger principle. We pour billions into finding brand new molecules. But this study is all about the delivery.
It's a field called implementation science, and it's so important. We have all these miracle drugs that fail in the real world because the regimen is just too hard for people to actually follow.
So it's about making it usable.
Right. The Ambition protocol shows that bioequivalence, killing the fungus in a petri dish, isn't the same as clinical equivalent.
Or in this case, clinical superiority.
Clinical superiority.
Yeah.
Exactly. In a hospital in East LA, the new way leads to far more people successfully finishing their treatment. And it makes you wonder about other difficult regimens. Tuberculosis, certain chemotherapies.
Are we asking too much of patients?
I think so. We often blame the patient for being non-compliant. We say, oh, they stopped taking their medicine.
But maybe it was a rational choice. If the treatment makes you feel like you're dying or costs you your job, is that non-compliance? Or is it just a reasonable response to a bad product design?
I think it's a rational response. And it's our job as providers to design regimens that fit into people's lives, not to demand they tear their lives apart to fit our regimen.
So why did it take a study in LA to prove this for the US? The original Ambition trial was in Africa, wasn't it?
Yes, the big landmark trial was mostly in sub-Saharan Africa. And there's often this resistance in U.S. medicine to adopt data from lower resource settings. There's an assumption that our patients are different or we have better resources so we can handle the toxicity.
A bit of hubris, maybe. We can manage the kidney failure better than they can.
That's exactly it.
Yeah.
And this study from LA General was so vital because it proved that, no, toxicity is toxicity. And patients in LA face enormous barriers, just like patients in Botswana.
It proved that it's not just a good enough for them solution. It's just a better solution, period.
It is the gold standard. The simplified protocol is the new gold standard.
So to wrap this up, who doesn't this work for? They did exclude some people.
Right, a couple of key groups. Anyone who is likely to die within the first 48 hours, because, no drug has time to work at that point.
Makes sense.
And this is really for what we call induction therapy, that first big assault on a new infection. If you have someone who's been failing treatment for months, you might need a more custom approach.
Got it. So for you listening, the big takeaway here isn't just about a fungus. It's about a shift in thinking.
Yeah.
From maximum tolerated dose to something more like minimum effective burden.
That's a perfect way to put it. Minimum effective burden.
And you see it happening elsewhere in medicine, right? Long-acting injectables for HIV instead of daily pills.
Single-dose antibiotics for certain infections, yeah. And every time we make that shift, adherence goes up and public health gets better. The friction of having to do something every single day is a huge barrier.
It's innovation through subtraction, taking things away to make it better.
Absolutely.
So the Ambition protocol, 1 dose, 2 weeks of pills, it cuts toxicity and patient walkouts by 2/3 with the same survival. It really feels like the case is closed.
I would say so. For any hospital treating this population, especially safety net hospitals, this really should be the default way forward. The LA data proves it works right here in our own complicated system.
And it reminds us that sometimes the best way to save a life is just to make sure the treatment itself doesn't ruin it.
For their kidneys.
Or their kidneys. Well, thank you for breaking this down. It's a dense paper, but the human story in it is just incredibly powerful.
My pleasure. It's a great example of real, meaningful progress.
And for everyone listening, think about that idea. Minimum effective burden. Whether you're in healthcare or design or really anything, are you asking people to endure a daily grind when a single-dose solution would work better? It's a question worth asking. Thanks for diving in with us. We'll catch you on the next one.